ask Dr. Venkat to start presenting the case.
Good evening, sir.
Good evening.
Sir, I'm Venkat from Shija Hospital, third year resident. I'm going to present right iliac fossa mass.
Okay.
Sir, is it visible?
Yes, it is.
Sir.
Venkat, you can also keep your video on also, so that.
Okay. Is it okay now?
Yeah, it is okay.
Yeah, it's perfect.
Yeah. Mr. A of age 52 years old gentleman, resident of Imphal East, daily laborer by profession. Came with chief complaints of right abdominal swelling since 3 months, passing black colored stool since 2 months, and right lower abdominal pain since 1 month. History of present illness. Patient was apparently asymptomatic 3 months back. Then he had a swelling in the right lower abdomen, which was initially 3 into 3 centimeters and gradually progressed to present size. There is no history of sudden increase in size of swelling or any other swellings in the abdomen. History of passage of black colored foul smelling stools in large amount since 2 months. The first episode was 2 months back and the second episode was yesterday morning. No history of constipation or diarrhea. History of pain in the right lower abdomen since 1 month, which started insidiously, then increasing in severity. Pain is dull aching type with intermittent in nature and aggravates on taking food and relieved on medication. No history of radiation or any associated symptoms. History of generalized weakness was present. And there is a history of unintentional weight loss and decreased appetite. There is no history of vomiting, fever, nausea, and no history of hematemesis, cough, SOB, or jaundice, back pain, headache, or convulsions. No history of difficulty in passing urine. Coming to past history, no history of similar complaints in the past. He was a known case of diabetic since 5 years and was on oral hypoglycemic drugs and on regular checkups. No history of TB or any close contact with TB, asthma, or hypertension. No history of any surgeries in the past. Personal history, he consumes mixed type of diet and he has adequate sleep. He is an occasional alcoholic and no history of smoking and allergies. Family history, he is married with 2 children and both his parents died due to natural cause. No history of pancreatic, colon, or prostate related cancers in the family members. Treatment history, he was on analgesics as advised by the local practitioner. Summary, based on my history, a 52-year-old diabetic came with swelling in the right lower abdomen since 3 months, melena since 2 months, and right lower abdominal pain since 1 month, and with generalized weakness and loss of weight and appetite. No history suggestive of metastasis. He was an occasional alcoholic and no significant personal or family history.
You have presented the history of a real patient or a virtual patient?
Sir, it is a real patient, but I took it long back, sir.
It's okay. That's fine. That's fine. So I think you are now talking about a patient who is 52 years of age. He's a diabetic. He has a swelling in the right lower abdomen for the last 3 months, and he experienced melena 1 month after the. No, keep it there. 1 month
Yes,
after the onset of lump, and then 1 month subsequently, he started having pain and generalized weakness, loss of weight and appetite. No history suggestive of metastasis. He is an occasional alcoholic and no significant personal or family history.
Yes, sir.
No, on the basis of history,
Sir.
What do you think your patient has? Can you sort of offer some kind of a working diagnosis on the basis of the history?
Sir, yes, sir. Based on his age and the symptoms of a lump in melena and loss of weight and appetite, I was thinking of more of a malignant pathology and tuberculosis, sir.
I think the two are quite different from each other, and let's, I think, discuss it in a little greater detail.
Okay, sir.
No, the most one of the very, very important thing, that you are expected to talk whenever you are, having a patient who has a lump in the right iliac fossa or right lower abdomen, where you have a possibility of a malignancy of the right colon or the right or the cecum. A very important information is sought in the history in the form of any change in the bowel habit, any recent change in the bowel habit. So I think that is very important thing that you have to very significantly and very pointedly mention. In your history, you have not mentioned anything about any recent change in his bowel habits, where what kind of history he has regarding number of stools, whether he is constipated, whether he is having now constipation with interspersed periods of diarrhea. So this is a very important history, that we should always try and elicit. And
Okay.
right,
Yes, sir.
when a patient has melena, by and large, it localizes the disease process to the bowel,
Luminal.
bowel, right? But when you
Yes,
use
sir.
the word melena, melena generally means black tarry stools, and black tarry stools occur when patient has a lesion just above the ligament of Treitz.
Yes, sir.
Okay, when there is an upper GI hemorrhage, then only patient has melena. So when you are using the word melena, you should be very clear about this connotation. Melena would mean bleeding occurring at or proximal to the ligament of Treitz. Okay, so if there
Yes.
is bleeding occurring, lower down, it presents as altered blood or hematochysia as it is called. So when you use the word melena, then it becomes quite, confusing. You should use the correct word, and if it's a melena, then you should be very clear that it is a melena, and you should be able to have a good explanation for this particular presentation. You got my point?
Yes, sir.
Melena is not used for lower GI hemorrhage, and your patient in the with a lump in the right iliac fossa or right lower abdomen is generally a patient who would have probably a lesion in the cecum or in the
Colon.
ascending colon.
Yes.
Okay, so I
Yes.
think that thing should always be kept in mind. Whenever the patient has bleeding, by and large, the disease process is in the gastrointestinal tract. Right?
Yes.
Melena stands for upper GI hemorrhage, and hematochysia and altered blood stands for the bleeding occurring distal to the ligament of Treitz. Okay,
Okay.
and
Okay,
bleeding
sir.
per rectum would refer to lesion in the anorectum giving rise to blood, and
Fresh blood.
this blood comes not mixed with the stools. So these are things that you have to keep in mind when you are talking about a patient like you have presented right now.
Okay, sir.
Now, do you say that you talk about pain? Now, you have to tell us what kind of a pain this patient has, right?
Yes, sir.
Now, pain in these patients, what type of pain do you expect?
Actually,
The
colic.
lumen of the right colon or ascending colon is quite large, and the stools are quite liquid here. So, we generally do not get a presentation in the form of uh, pain, but sometimes patients do can have colicky pain when the lumen gets more and more compromised. It's nothing, not that they can't have it, but generally they don't have it because the lumen is very large, and the lumen has to really get compromised to a critical diameter for the symptoms of pain to appear, and that time the symptom of pain would be that of a colicky type of a pain, classically experienced in the lower abdomen. The lower abdomen is the area of hindgut representation as far as the neurology is concerned. The hindgut organs, when they give rise to pain of visceral origin, the pain is experienced in the lower abdomen below the umbilicus or in the hypogastric. In today's context, also, it is very important, that using the word hypochondrium, and lumbar region, and iliac fossa. So I think nowadays, the better classification system that is there is right upper abdomen, right lower abdomen, left upper abdomen, left lower abdomen, epigastrium, umbilical region, and hypogastrium. So this is how we refer to these areas, because if you see if you look at the hypochondrium is a very small area which is just behind the rib cage, right? Anything happening there will not be palpable or will be barely palpable. It has to come down to the lumbar region to become palpable. So nowadays, I think most of the books have started referring to lumps in the form of right, left, uh, right and left upper abdomen, right and left lower abdomen, and then of course you have hypogastrium, umbilical region, and epigastrium. Okay. Now you're talking about tuberculosis in this patient, right? Now, why should you think of, yeah?
Nothing, sir.
Why should you think of tuberculosis? Now, in tuberculosis, if your patient has some concomitant manifestation of tuberculosis in the lungs, like if your patient is having cough, or he's having sputum, or hemoptysis. These are things, which suggest that a patient may be also having tuberculosis somewhere else. That's one thing. Then, by and large, the age at which tuberculosis presents is generally in the 20s, 30s, and not in the 50s. But 50s, a patient of diabetes are at risk of developing tuberculosis, so they can definitely have tuberculosis even in the 50s also. So the age doesn't rule out the tuberculosis. What is more important is the duration of history. The history in a patient of tuberculosis is a history which is history that goes in months or years, right? Because the tuberculosis results in cicatrization and fibrosis. And this process evolves over a long period of time. And classically speaking, patients have what is known as moving ball of wind. Have you heard this term, moving ball of wind, which starts in the upper abdomen and moves with gargling sounds into the right iliac fossa? It's just like a ball which is moving, ball of wind moving from left upper abdomen down to the right lower abdomen. So that's a kind of a presentation which a patient of tuberculosis would have, because tuberculosis results in narrowing at the ileocecal junction. And when the patient has a slowly evolving narrowing at the ileocecal junction, he tends to present more with the what is called as moving ball of wind and picture of subacute bowel obstruction. And picture of subacute bowel obstruction, I have already mentioned this as alteration of constipation with loose motions. So these are the things which happen in tuberculosis. So on the basis of history itself, it will be very difficult for me, to accept this to be tuberculosis, because it is a short duration thing. Okay. Would you consider this to be an appendicular lump?
No, sir. Because appendicular lumps present as an acute history, sir. Within 1
Yes,
week.
I think the way this patient has presented, that he is a sort of first symptom that he experienced was a lump. In a patient of acute appendicitis resulting in a lump formation, the first symptom will always be pain. And there is some sequence: pain, vomiting, and fever. That's the sequence in a patient of appendicitis. If this sequence is not being followed, then you have to question the diagnosis, right? If your patient is having, vomiting first and then he has a pain, you have to question it. Similarly, if your patient is having a lump first and then has pain, you have to question the diagnosis of appendicitis. Okay. So yes, you have a male patient or a female patient. I think it's a male patient.
Male patient, sir.
Huh?
Male patient, sir. Male patient.
Male patient. Okay. What else can you think in this patient? So we have looked at, bowel pathology in the form of tuberculosis, bowel pathology in the form of malignancy of the right colon. we have looked at a possibility of appendicular lump, which we have rejected very summarily on the basis of presentation. Is there anything else that we can think of?
Sir, we can think of any GA lymphoma, sir.
Lymphoma. Why should you think of lymphoma?
It arises, but in patients of GA lymphoma, there is less likely to be history of.
No, I think lymphoma is kind of yes, lymphomas tend to occur in this region, no doubt about it. But you have to have some kind of a when you take the when you do the examination, probably you will mention that. But one will have to have some kind of a clue to that diagnosis. There is no clue that it could be a lymphoma. Another common lesion, that you should always think of is what's called as GIST, gastrointestinal stromal tumor. Now, these are the ones, which are known to occur in all segments of bowel, and for whatever reason, they are becoming much more common than they used to be in the past. Right. So I think GIST should always remain in the background. Of course, that would be a histological diagnosis. But when we are looking at the possibilities, these are the things that we can have. GIST can give rise to a lump, GIST can bleed because there is some kind of a central necrosis, and it can bleed and give rise to bleeding in the GI tract. And by impinging upon the lumen, it can give rise to also features of features of pain, the like this patient has been experiencing. So I think these are the things that one should consider. Should one consider other diagnoses other than GI diagnosis?
Sir, might be sometimes psoas abscess are long duration and retroperitoneal sarcomas.
Retroperitoneal tumors, lymph node swellings, psoas abscess, all of these things are known entities which can give rise to a lump in this particular region. But psoas abscess would suggest that patient has some kind of a tuberculosis or some kind of a spinal problem, and then or not all psoas abscesses are because of tuberculosis. There are also non-tuberculous psoas abscesses which present more with the fever and uh, features of sepsis, right? So this patient doesn't have that. No,
No, sir.
whenever patient has, so first and foremost, so therefore, if you have to summarize our approach to a lump in the right iliac fossa, first and foremost thing would be to see if there is anything to suggest that it is arising from the bowel. And, there is something to suggest that because he has bled, and then, of course, your interpretation may be wrong, that it is melina, it may be just a altered blood which appears a bit black. Just a minute, give me a little time. Sorry for that. So we should always look for anything that can point that the patient may be having a lump arising from the bowel in this region. And that would be, as I mentioned, altered bowel habits. Okay. Then any episode of hematochezia and subacute bowel obstruction. So these are the things that you have to look for. Whenever any of these things is present, your focus should be that it could be a lump arising from bowel in that particular region, right? And bowel lumps we have already discussed. And we discussed very thoroughly that why it is not an appendicular lump, right? And I also mentioned, that you could always think of some kind of appendicular carcinomas also. Of course, there are no features here, but these are also the possibilities which will be more like, diagnostic surprises when we investigate these patients. Okay, so let's move on to examination. So that's how you should assess, and you should sort of analyze your patient's findings.
Okay, sir.
Okay, move on.
Yes. General physical examination. After taking an informed consent, I have examined the patient in a well-lit room with adequate exposure. Patient was conscious and oriented to time, place, and time. He was moderately built and moderately nourished with BMI of 20.1 kg per centimeter square. ECOG score of 1. Pallor was present. No icterus, cyanosis, lymphadenopathy, clubbing, or pedal edema. Vitals. Pulse rate 94 beats per minute in right radial artery with normal volume, regular rhythm, and normal condition of vessel wall. All the peripheral pulses are felt equally on both sides. Blood pressure 110 by 70 millimeters mercury in the right arm in supine position. Respiratory rate 18 breaths per minute. Temperature 98.5 degrees Fahrenheit.
So can you just give us the gist of your general physical examination?
Sir, he's
Gist
having
of your general physical hemodynamically stable patient.
Yes, sir.
No pedal edema, no lymphadenopathy, no jaundice.
Pallor was this.
Except pallor, everything is all right?
Yes, sir, except pallor.
Right. So your patient has this pallor, and then on another important thing that you have mentioned is ECOG's grade
Score.
1. ECOG
Yes,
1 means that he is a good risk patient. If a surgery is required, he is an active patient, and therefore he is expected to be a good risk patient for any kind of surgical procedure if that is indicated.
Yes, sir.
Okay, so that's the information that we have from the general physical examination. Now, if your patient has a pedal edema, that means
No,
that no. If your patient has pedal edema, it's a poor risk. It's an indicator of a malnutrition. It's also an indicator of severity of the disease that he's suffering from. Okay, so remember this pedal edema is not only a marker for hypoalbuminemia, it's also a marker for the severity of the disease. Any patient suffering from a catabolic stress imposed by the disease is likely to manifest what pedal edema. So pedal edema is a marker for a kind of severity of disease, a higher severity disease patient. Not only albuminemia, and albuminemia only occurs in those patients, who have a severe disease. It's not simply a nutritional thing. It's a severity of. It's an indicator of severity of the disease. Okay. Now you talked about lymphadenopathy. What is the What the kind of lymphadenopathy this patient has or doesn't have?
he doesn't have, sir. No lymphadenopathy.
Okay. So what lymphadenopathy we are looking at? We are looking at we are looking for the supraclavicular lymph nodes, right? So you're looking
Yes.
at the supraclavicular lymph nodes, Burko's lymph nodes, which are present between the two origins of the sternomastoid on the left side. But it's only not only these lymph nodes. There are also lymph nodes on the right side also, right supraclavicular lymph nodes, and also you should look for axilla also. And in this context, it also becomes important if your patient is having a lymphadenopathy, significant lymphadenopathy in the axilla or in the inguinal region, then you should suspect what you were telling at the time when we were discussing the differential diagnosis. You should suspect lymphoma in those patients if they're having large lymphadenopathy in inguinal or axillary region, right? But as far as your patient and general physical examination here in this patient is concerned, we have two important things. Is ECOG 1, number 1, and number 2, that he has anemia. Rest, everything is all right. Move
Yes.
on.
So coming to local examination, on inspection, abdomen is flat with fullness in the right iliac fossa. Umbilical is central and inverted. No dilated vein, sinuses, or scars. All quadrants are moving equally with respiration. No visible peristalsis or pulsation. External genitalia and hernial orifices are normal. Renal angles are normal.
So on inspection, okay, let's see. So you find small fullness in the right iliac fossa or right lower abdomen. Umbilicus is central and inverted. No dilated vein, sinuses, or scar.
3 miles.
Okay.
19
Okay. Visible veins, right. External genitalia is normal and renal. Fine. That I think is a very good local examination, and everything that needs to be known is mentioned here. Okay.
Yes. On palpation, temperature is normal in all the quadrants. An intra-abdominal, intraperitoneal non-tender lump of size 18 to 8 centimeters in the right iliac fossa, which is extending into right lumbar and umbilical region, having nodular surface and round margins and hard in consistency, and moved horizontally. Lump does not move with respiration. No other abdominal lumps are palpable. Palpation of renal angles and left supraclavicular regions are normal. Hernial orifices and external genitalia are normal.
So you have this patient who's got an intra-abdominal, intraperitoneal lump. So why do you how do you say intra-abdominal and intraperitoneal?
Sir, on asking the patient to raise his both the legs,
Mm-hmm.
The abdominal muscles will get taut, and we can
Mhm.
differentiate the intra-abdominal and parietal lump, sir. If it is becoming prominent, that is a parietal lump. If it
Right,
is if it is decreasing, then it is intra-abdominal lump, sir.
right. So how do you conclude that's a intraperitoneal and not a retroperitoneal lump?
Sir, on asking the patient to turn to the lateral side,
Mm-hmm.
the lump moves. It's changing the position of the lumps. It moves laterally to the opposite sides.
Mm-hmm.
If it is fixed, it is retroperitoneal.
So by and large, a lump which is mobile is considered to be not arising from the retroperitoneal, right? Which is it is considered to be not a retroperitoneal lump. All
Yes.
retroperitoneal lumps would have very restricted mobility. If your lump is changing position with the change of position of the patient's posture, then it is very likely that it will be intraperitoneal and not retroperitoneal. Okay.
Yes.
Now, we do not know from where the lump originated. We know what areas, what particular area in the abdomen this lump is occupying. So we should not use the word extending. You should be using the word occupying these areas, right?
Okay, sir.
So what are the areas that this lump is occupying? This lump is occupying the right iliac fossa and right lumbar and umbilical region. In this context, it would not be important, to tell us, what is the lower limit of this lump and make it in relation to any particular, anatomical landmark, upper pole, up to what level that upper pole is reaching, and
Sir,
medially, how far short of midline it is. So you can give a better picture of this lump, by giving the idea that what is the level of the lower pole of the swelling, what is the level of the upper pole of the swelling, and how far medially this swelling is extending. So that will give us a better picture of what size of lump this patient has, right? Rather than telling us that what areas, what quadrants it is occupying, right? So you have a fixed landmark like umbilicus, you have a fixed landmark there. You have midline, which is a fixed landmark there, right? You have pubic tubercle, and you have this anterior superior iliac spine or iliac crest. So you can give a reference, that this lump, the lower pole and upper pole and all of those things, you can clearly mention. And then, your lump is going up to the, as you mentioned, the lumbar region. So is your lump bimanually palpable? Have you
no, sir.
mentioned about this?
Not mentioned, sir.
So I think it's very important for us to know that any lump which is present in the right iliac fossa can be bimanually palpable, provided it can be accessed both from the anterior and the posterior aspect. Right. So I have my hand in the renal fossa, and I have my hand on the swelling in the lumbar region. And if the swelling is of some size, then it should be amenable to bimanual palpable. Okay. Generally speaking, it is the kidney lumps which are bimanually palpable, but any lump present in the right iliac fossa can be bimanually palpable. Whether it is a colonic lump, whether it is a retroperitoneal lump, whether it is a kidney lump, or whether it is a lump arising from a large lump arising from the, let's say, adrenals, right? Sometimes adrenal lump could be very large. So any lump present in the present in the lumbar region can be bimanually palpable, provided it is large enough that a palpating hand and this displacing hand can appreciate it, that it is large enough. If it is very small, it may and it is not reaching the posterior abdominal wall, that's a different thing. But if it is large enough, you should be able to palpate it. And why colonic masses are generally not bimanually palpable? Because they are not very large vis-a-vis kidney, and they do not reach the posterior abdominal wall, and therefore they are not palpable. It is only the kidney masses, which become very large and can be simultaneously touching both the anterior and posterior abdominal wall, right? So that's what you should remember. Somebody said that right iliac fossa. We are not talking about right iliac fossa mass. We are talking about mass which is present in the right iliac fossa, which is also reaching up to the right iliac fossa, but is also, sorry, we are talking about a lump which is present in the lumbar region and is also extending into the right iliac fossa, right? So if the lump is palpable in the lumbar region, we should be able to have a bimanual palpability if it is a large enough lump. Mere fact that it is extending into the right iliac fossa will not come in the way of its palpability bimanually in the lumbar region. You got the point, Sham? Hello?
So yes, sir. Yes, sir.
Okay. So that's the discussion that we need to have, and basically be able to graphically represent the lump in relation to fixed anatomical landmark, and also mentioning about the bimanual palpability is also very important. Okay, next, move on.
Sir, on percussion, a liver span is 12 centimeters. Lump is dull on percussion. No evidence of free fluid. On auscultation, normal bowel sounds are heard. No abnormal bruit over the lump. On distal rectal examination, no growth or deposits. Black color stain over the finger. Systemic examination, CVS examination, normal heart sounds were heard. No murmurs. Central nervous system examination, no evidence of neurological deficit. Respiratory system, normal vesicular breath sounds. Musculoskeletal examination was normal. Summary: a 52-year-old diabetic with swelling in the right lower abdomen since 3 months, melena since 2 months, and right lower abdominal pain since 1 month, and with history of generalized weakness and loss of appetite and loss of weight. No history suggestive of metastasis. General physical examination was normal except for anemia. On palpation, a non-tender intra-abdominal intraperitoneal lump which is irregular in surface and hard in consistency and can be moved horizontally. Lump is dull on percussion and no evidence of free fluid. DRE was normal except for black color stool over the finger.
The first is that you have to really sort out this confusion in your mind. Black color. It should be, blood, or you can say, uh, uh, sorry, you should say that there is blood stain, or there is a altered blood stain on the finger stall, and not black. Black would definitely take you to the, as I mentioned, upper GI hemorrhage, and that's what you don't want here. It's not upper GI hemorrhage. The black, violet color is, the color of blood, violet color, just like the color of a violet, what should I say? Just like, color of an eggplant for that matter. So, so Miss Ghosh, I'll just call you back in some time. Okay. So when you use the word black, then it gives it away that you are talking about bleeding from upper GI hemorrhage, which is not the case. And then you are trying to get into unnecessary muddle. You should try and stay away from unnecessary muddle. Try and explain each and everything on the basis of one pathology. Don't try to invoke more than one pathology in explaining the patient's condition. So you should always look at things from that perspective. Never try to invoke two pathologies, as somebody has mentioned here. Okay, so that's that. What should we be now doing? We have discussed the differential diagnosis on the basis of this particular history. When you have a lump, a well-defined lump of the type that you are mentioning, only two diagnoses become quite close, and they are, what are the two diagnoses which are close here in this patient? carcinoma of the cecum, or maybe GIST. These are the two diagnoses, which remain quite favorite. But tuberculosis generally doesn't present as such a large mass with nodular surface. It presents as a kind of a mass which is not very large. On the surface, it is smooth. It's not nodular. It's not. It's more like a rubbery, not hard. So, but history also has to be taken into consideration. So, all of these things together, probably we are dealing with a patient of carcinoma of the cecum or carcinoma of the ascending colon. Now, how do we prove what we are dealing with?
Sir, I'll investigate the patient, sir.
So, how will you investigate this patient?
Sir, as the extension of my clinical examination, I'll go for ultrasound whole abdomen, sir.
Okay.
Because it is a non-invasive test and easily available. In ultrasound, I'll see the organ of origin, any lymph nodes are involved, any ascitic fluid is there.
Yes.
The actual size of the tumor.
Okay.
And its relation to the surrounding organs.
Not really. I think that is so we can definitely establish that this is a mass arising from the colon, right?
Yes.
Now, that is something that we can always establish on the basis of ultrasound, that it's a mass arising from the intestine or the colon or cecum in that particular region, or from the ileocecal region. So that's what we can establish on the basis of ultrasound. Whether it is carcinoma or whether it is tuberculosis, can we make a sort of intelligent guess which one it is?
More likely to be carcinoma.
No. On the basis of ultrasound, what are the features of the ultrasound which will tell us that it is more like a cancer and not tuberculosis? In tuberculosis, there is a circumferential narrowing. Here you will have some kind of a mass lesion within the lumen of the bowel, right?
Okay.
And lymph nodes can be present in both the conditions. Okay.
Yes.
And as you were mentioning, we can pick up ascites very well. We can also pick up metastasis in the liver.
Yes.
We can pick up lymph nodes around the lesion and also around those major vessels. We can also have a good look at the pelvis and look for any deposits in the pouch of Douglas or in the plumber's plumber's shelf. So these are the things that you can do on the basis of ultrasound itself.
Yes.
So all this information is available. So possibly it is a mass arising from the cecum. Now what will you do? What's the next investigation?
I'll confirm my diagnosis by doing the colonoscopy, sir.
You will confirm your diagnosis by doing colonoscopy. Okay.
Yes, sir.
So what all you would look for? What is that you are trying to look for on the basis on colonoscopy?
On colonoscopy, the origin of the growth.
No, origin. Okay, you can say we are looking the lumen for any luminal pathology.
And any other associated synchronous lesions or any polyps.
Yes, very important to remember that colonic carcinoma can be multifocal, and therefore there could be some synchronous lesion which will alter the way we would manage these patients. Okay.
Yes.
We can also have some of those pre-malignant conditions which may be responsible for the patient to have developed cancer in the first place, like ulcerative colitis and things like that, or polyposis for that matter. Right. So these are the things that we can pick up on the basis of colonoscopy. And in today's time, colonoscopy is a standard of care. Even if you've got a diagnosis of a mass lesion in the cecum on the basis of ultrasound, you have to examine the rest of the colon and also look for any possible pre-malignant condition that the patient may have that would have some bearing on the treatment that you will offer to this patient. Okay. So colonoscopy is quite important, and you would definitely go for colonoscopy and take a biopsy. And what are the various biopsy findings or biopsy results you can have?
Sir, we'll have the adenocarcinoma, sir,
Adenocarcinoma?
or it's a simple adenoma.
Why adenomas won't present with such a large lump? You were saying something very useful earlier on, but you've changed.
Lymphoma, sir.
Gist you can be there, and lymphoma can be there.
Yes.
Lymphoma, gist, and of course adenocarcinoma is the favorite. So these are three things that we have which may be present, and we will take a biopsy. And biopsy comes out as what could be the histology of this lesion? If it's an adenocarcinoma, what are the things that we are going to look for on histology?
No.
Mucinous or non-mucinous, right? Mucinous adenocarcinoma or non-mucinous carcinoma. We'd also have a possibility of well-differentiated or poorly differentiated carcinoma. Microsatellite instability, MSI index,
Yes.
right?
Yes.
And so these are the various things that we look for on this, and they have a bearing on the overall prognosis of the patient and something like uh, overall bearing on the treatment. And what's more? What's
Other
my question? Can you repeat my question?
Sir, you mean other investigations, sir?
What I was talking to you about is that when we are talking about the histology of the lesion, it has a bearing on the prognosis and also on the neoadjuvant treatment that is proposed for this patient. Okay, so the neoadjuvant treatment that you will give to this patient will differ on the basis of histological picture. So this is what we get from them. Okay, so that's why we always do a colonoscopy in these patients and do all of those things like we have discussed. What else?
To stage the disease, we'll go for CECT abdomen, sir, and pelvis.
Yes, CECT abdomen. Before that, would you like to do this CEA estimation?
Yes, sir. To support my diagnosis and for the prognostic in the post-operative period.
Any other view about this?
CA level, sir.
Yeah.
It will, if the levels are very high, it will indicate the penetration of the bowel walls.
See, CEA are important from these perspectives that you are mentioning. Very important is first and foremost is to establish whether this is a CEA producing tumor or non-CEA producing tumor. All colonic carcinomas are not CEA producing tumors. So you cannot use it as a marker subsequently for any recurrence if it is not a CEA producing cancer in the first place. So you remember that. Second is that CEA levels may represent the volume of disease, the extent of the disease. Okay, the higher the level, the higher is the chance that the patient has a high volume disease. Okay, so it can be used as a monitor. Generally, it is used as a tool for finding out the recurrence or monitoring the patient for recurrence subsequently. And therefore, first we have to establish that it's a CEA producing tumor or it is not a CEA producing tumor. Okay, so you would always do a CEA examination in these patients. And then the next is if we find that, okay, our patient is operable. So when do we say our patient is operable?
Sir, if there is no evidence of any liver metastasis,
Yeah,
peritoneal deposits or omental
Yes.
deposits,
that's
and
right.
ascites,
Yes,
and fixity to the surrounding structures like ureter or duodenum.
that will come to in a while.
Okay.
First is operable. Operable means can we subject this patient to operation? So his general condition has to be good.
Yes.
Okay, and there has to be no evidence of an advanced disease. If the patient on the examination has features of advanced disease, right, he is inoperable. If patient is not, in good physical condition as measured by ECOG scale, then again, he is not operable. So we cannot offer surgery to patients, who are cardiovascular crippled, We can't offer patients, who are having extreme cachexia. We cannot offer surgery to those patients who have got metastatic lymph node in the axilla, or we can't offer surgery to those patients, who have large lymph node, this liver mets, So upfront, if we have grave signs of metastatic disease, this patient is inoperable. And if the patient has uh, very advanced cardiovascular disease or a very poor performance status, he is out of reckoning for surgery. That should be clear. So now we move to the next aspect. First is we have decided on the basis of our workup so far that patient is a good risk patient. He doesn't have features of advanced disease, and we can offer him surgical treatment if his local disease is amenable for it. So now we are going to look for resectability. So resectability, and also if we want, we can have a further metastatic workup if we need that. So how do we know about the resectability of the disease?
Resectability. In the CECT, we can know, sir.
CECT is a very good investigation to help us know whether the disease is resectable or not resectable. Any patient who's got, direct extension of the disease into the parietes or to the ureter, right, would be, and disease can also extend to the duodenum, because duodenum is not very far from the right colon. This is a tumor extending 8 centimeter from the cecum, so it is just very close to the duodenum. So we will have to look at whether it is involving the duodenum or it is not involving the duodenum. Okay, so, and of course, when we do the CT scan, we'll also have a better understanding of.
Hello, sir.
I think we have lost connection. I'll just try to sort it out.
Shyam, what happened?
I just check. I just call sir and get back.
Oh, thank you.
Now it's fine, sir. Yeah. Sir, are you with us? Hello. Sir, I think we got disconnected. Yes, sir. I think we need to. No, I mean, the class is on. You got disconnected.
All right. Now I can see you.
Now it's fine, sir. Yes, sir. I mean, temporarily it got disconnected, sir.
Okay, that's fine. Okay. So what I was telling you.
Sir, resectability and operable.
Yeah. So we were talking about resectability, and we do the CT scan, and I was mentioning that surface metastatic deposits on the liver are poorly assessed by all the investigations, right? If there are small deposits sitting on the liver, they are poorly assessed by CT scan. Similarly, if there are peritoneal mets, they are also very poorly assessed by the CT scan. So we will have some diagnostic surprises in situations when we open and find out that, though of course we investigated this patient thoroughly, but still these were missed. So there are no foolproof methods to assess this resectability based upon involvement of the peritoneum or the surface of the liver. I'm not talking about the liver mets as say surface mets on the visceral aspect of the liver, right? There are of course deep metastases which are very well picked, but these superficial ones on the surface are not picked very well. So these are the things that you have to remember. I'll answer this question which Tanushree has asked. So in this situation, what is the current understanding? Current understanding is that PET scan may give you an idea that what is the other spread available, or whether other spread has taken place. So you can do a PET scan examination and know far more about it. And I think the time is not very far when PET scan will be standard of care for these patients. But at the moment, PET scan is not being used for this overall evaluation because of its cost and also because of its non-availability in most of the places. So PET scan is a good investigation which can help us understand the disease spread. In the meantime, we can always do a diagnostic laparoscopy before surgery. And if we are doing open surgery, of course, the diagnostic lab can be done by anyone, and you can do a good diagnostic lab and see if a patient has any of those situations which negate surgery. Otherwise, you can go ahead and perform the surgery. And if you are doing a diagnostic, if you are doing laparoscopic surgery, so much the better. The diagnostic lab is always a part of it. So the next investigation in this patient is generally diagnostic lab just before the definitive surgery. Okay, definitive surgery could be a laparoscopic surgery or could be a conventional open surgery.
Okay.
So that's the workup of a patient, which I think we have very thoroughly discussed. And now, what do we need to do for this patient?
Sir,
This patient, let's say that this patient has a large lesion, which is not involving the retroperitoneum, which is not involving other organs, and which is kind of having some lymph nodes in the vicinity, but lymph nodes in along the major vessels like middle colic and ileocolic are not involved. So what will we do for this patient?
sir, we'll do right hemicolectomy, sir.
No, I think right hemicolectomy for these patients is not the right answer.
Extend.
It is it's a type of hemicolectomy. It is a radical hemicolectomy. Now, radical hemicolectomy is different from standard hemicolectomy. So, what's the difference between the right hemicolectomy for cancer and right hemicolectomy for a benign lesion? That is a question that you have to look for an answer from your own resources. But remember, there are types of things that you should know. Hemicolectomy, right and left hemicolectomy. Then you have to know about radical hemicolectomy for cancer. And then you have to know what is extended hemicolectomy. So I'm introducing you to these terms, and I would expect you to look for these terms clearly from your books. And also like that whatever we have discussed, you go back to your books and read them thoroughly so that whatever we have discussed becomes your permanent knowledge. And if you find something which we have discussed which is given differently or which has been given a different size and shape by the books that you read, that by that I mean that if you find that the points that we have made here are at variance from what is there in the books, do come back to us, so we'll try to resolve those issues. Okay, in the meantime, I would ask you and I'd like you to read these three operations that I have mentioned and know the difference between these three. One, right hemicolectomy for benign condition, then right radical hemicolectomy for cancer, and third, extended hemicolectomy. What do we mean by extended hemicolectomy? Right. So all these words have been very clearly defined in the literature, in the books. So I would like you to read these things, and in our next class, if you can make a small presentation on various types of hemicolectomy, that would be welcome.
Okay, sir.
Right. And I must say that Venkat, you presented very well, and you appear to be a very thoroughly prepared postgraduate. And if you make a similar kind of presentation in your exam, I expect that you will pass your exam.
Thank you, sir.
Keep it up. And
Yes,
all
sir.
of you, guard up your loin and start preparing hard. I think in the meantime, I have answered the question which Tanushri had raised about PET scan as an important investigation. And I think now PET scan are being done, more in the setting of, follow-up of these patients when they tend to develop some recurrences. But as a standard of care, they have not yet become accepted in the overall flowchart for the investigation and management of these patients. And the reason I've told you is the cost and also the scanty availability of this modality of investigation. Sham,
Yes,
is it
sir.
fine?
Yes, sir. We have another one doubt, sir, from Dr. Siddharth. Is bladder or rectum invasion resectable at any point?
See, I think extended resections, now that you have asked this question, whenever we have to remove another organ, it becomes extended resection. So extended resection. Well, in extended resections, if the disease is extending to the bladder or to the ureter, and as you know, for those conditions, where surgery is the mainstay of treatment, you can do multi-visceral resection. For example, if a part of the ureter is required to be sacrificed, so do it. Even if you are not able to achieve an R0, you will create a situation where you can control the disease with radiation also. So try to do an R0 resection if the disease is amenable to resection, right? So that means that if your part of the ureter needs to be removed, do remove it and do a end-to-end anastomosis. If a part of the bladder is involved, and you can remove it and achieve an R0 resection, do it. Similarly, if the part of the duodenum is involved, not necessarily you have to do a Whipple's operation. You can remove the part of the duodenum and do some kind of a Thal's patch or serosal patch repair of that. So aim is to be able to do R0 resection. And in this situation, neither radiation nor chemotherapy is supposed to be very effective in controlling the local disease. It's good when there is a very small disease left after surgery. Now, if I have a large lesion, and I give the patient radiation upfront, it is not likely to achieve much. But if I have removed that lesion and give radiation to the areas, where I had close resection margin, patient can have a good control of his disease, and some of these patients can get also cured also. So this is what is meant by extended resections. Okay, so understand these terms, and I'm really happy that we could discuss this case very thoroughly this Friday evening. So next time, I think when we meet, we'll have another class on another subject and by maybe another presenter, but done with the same zeal and with the same commitment and same passion.
Thank you, sir. Thank you.
Okay, and I think this topic is now open for you to go and read in your study and develop better understanding about this subject. Do read it thoroughly tonight.
Okay, sir.
Okay, all the best.
Thank you, sir.
Sir, thank you, sir. We can close the meeting, sir.
Yes, please.
Thank you, sir.
Thank you, sir.